I've noticed that the older I get, the less I like change. However, I've also learned that change is inevitable. Change is going to occur, and there's really nothing that I can do to stop it. I'm only responsible to respond to it. Now, I could respond to change whenever it comes by sticking my head in the sand and doing nothing. I could fret and worry about the change or even complain about the changes coming. But none of those are going to lead to any kind of a good outcome. So frankly, all of those are a waste of time. But I also could choose when change comes to respond and to accept it and then to respond to that accordingly. And normally when I do that, something good and positive can come out of it. And so I say all that to say this. Most of you have heard by now that Medicare 2026 is going to be the year of changes. In fact, many have said that Medicare 2026 is Medicare resetting itself. And so the question is, do you know what's changing for 2026 and why? But most importantly, do you know how you're going to respond to those changes? And so those are the topics I'll be covering in this video so that when the changes come, you respond properly and something good can come out of it. Now, change is going to be affecting all the parts of Medicare in one way or another. So in this video, we're going to talk about Medicare A and B, supplemental plans, drug plans, Advantage plans, so that you're aware of the changes. All right, so we'll begin here. If you're no longer working, your spouse is no longer working, you are on Medicare A and B. So what's changing for next year? So let's first talk about Part A. Part A, of course, is that inpatient side of Medicare, covers hospitalization, skilled nursing, and hospice care. And so right now, the majority of you watching this, you're paying zero for your Medicare Part A, because as long as we paid into the Medicare tax system for at least 40 quarters, which is 10 years worth of working, or our spouse did, we don't pay any premium for Part A because we pay for it all of our life. Now, 1% of the population actually pays for Part A, and right now, if someone has 0 to 29 quarters, they're paying $518 a month for their Medicare Part A. If they have 30 to 39 quarters, they're actually paying $285 on a monthly basis for their Part A. So some people have to buy it. I would suspect those are probably going to go up a little bit next year. Medicare has not given us all the numbers yet. I'm shooting this video. It is October the 6th, so they haven't announced them yet. We're anticipating them to be sometime this month or maybe even into November. All right, so that is Medicare A. Let's talk about Medicare Part B. Now, the majority of you watching this, majority of Americans are paying $185 a month for their Medicare Part B. Again, we don't have the number yet for 2026. Most are saying they're anticipating an increase somewhere around $20 to $22 a month. So we are expecting that to go up. That's about 10%, maybe even 11%. And so if you're on Social Security, that Part B comes out of your check. If not, you're being billed quarterly, or they have some kind of a bank draft set up with you. Now, the Medicare Part B premium is based upon income. A was based upon quarters. B is based upon income. And so what Medicare does is they establish thresholds. And so what they look, if you're on Medicare this year, 2025, they're looking at 2023, 2026, they're going to look back at 2024 modified adjusted gross income. That's line 11 on your tax return plus line 2A. Those two combined become modified adjusted gross income. That number determines how much you pay for your Medicare Part B. So if you're a single filer, if your modified adjusted gross income is $106,000 or less, then this year you're paying $185. If you're married filing a joint return, that number is doubled, so it's $212,000 or less. You're paying the $185. All right, so that's about 85% of the population or so would be in this bracket here. However, some of you are considered to be high income, and so you're having additional charges beyond the 185. We call these IRMAs. This is an acronym that stands for Income-Related Monthly Adjustment Amounts. And so as they look back 2 years, so in 2026, they're looking back at 2024, if you're going to be above the thresholds, you're going to have an IRMA, a surcharge. Now, we anticipate next year for 2026, these thresholds are probably going to go up a little bit. I would say somewhere around the $109,000, $110,000, and of course doubled in if you're married filing a joint return. But the point is you're going to have an IRMA. Now, the IRMAs right now, we actually have 5 levels of IRMA. I'm not going to go through all those, but the lowest IRMA right now is right about $87 and some change. And the highest IRMA, the 5th level, is right around $527 a month and some change. So they take the base and they add their IRMA to that, and those IRMAs also include a small IRMA on the Part D. So if I have an IRMA on B, I also have an IRMA on D. All right, so this would be the A and B of Medicare. And again, we're anticipating some of these to change a little bit. Those numbers are just not out yet. All right, that brings us then to supplemental plans, also called Medigap policies. So when people are enrolled in a supplemental plan, they have chosen to stay in original Medicare A and B that pays first, but because Medicare doesn't pay for anything 100% other than preventive services, people will buy a Medigap policy, a Medicare supplemental policy, to fill in those financial gaps either fully or almost in full. All right, so let's talk about what's changing for these plans. So first off, I want to draw your attention to what we call the Medicare AEP. This stands for the Medicare Annual Enrollment Period. And that's exactly what we're just about to be involved in that period of time, the AEP, October 15th through December the 7th. And so what does this period of time have to do with supplemental plans? And folks, absolutely nothing. Okay, we don't have the AEP, this annual enrollment period, because of supplemental plans. We have it because of Advantage plans and drug plans, which are annual plans. So this period of time has nothing to do with MedSups because MedSup plans, all of them, are written for life. They're truly lifetime permanent plans. The only thing that can change on those would be the premiums, and they don't go up necessarily during this period of time. They go up at different times depending upon the carrier and when your policy started and when your birthday is. And so the whole point is this period of time really has nothing to do with it. Now, that doesn't mean to say you can't make some changes during this time, but Medicare supplemental plans actually can be changed at any time. Now, we normally have to go through underwriting to make that kind of a change, but again, we are not tied to the annual enrollment period. And the reason I'm mentioning this, if you decide to make a change now, and you can, just know that there's going to be millions of people doing it. So the sooner you get changing your supplemental plan, the better, because you got to get in line. We got to go through underwriting. And so as we progress through these dates, as we get into probably mid to end of November, these companies really get backlogged. And so underwriting becomes a longer process, a slower period of time. And so again, if you're going to change plans, you can do it this time, but you don't necessarily have to. Many of you are already on the best plan for you at the very best price for you. But if you do switch, I would encourage you to do it relatively soon. Now let's talk about rate increases. We have frankly seen more rate increases in the last 2 years than we have for years prior. I've been in this business almost 17 years. Last 2 years have been somewhat challenging for rate increases. And the reason for that is frankly because of all the inflation that we've experienced in our country. We're hoping that's going to stabilize and we'll see some of that within the MedSup business. But right now, a lot of medical inflation has occurred, and that's impacting the cost of medical care. Medical inflation is actually higher than the average inflation on a lot of other goods and services. And so that's just a reality, rate increases. Now, there's a second reason it's kind of interesting, and that's this. And I think this is really going to change as we get into 2026. But up to this point in time, all of 23, 24, and some of 25, what was happening is people have returned to getting proper care. Why? Well, during the COVID years, a couple of years, people delayed care. They didn't want to go to the hospital. They didn't want to have that surgery unless it was really necessary. And so they delayed the care. And then once that passed, now people are back to using services more. And we're seeing an increase of claims. And so that also has affected the stability of the rates. Number three, we're also seeing a new trend. And that trend is that many people, as they approach the age of 63, 64, 65, and maybe they need some kind of a major surgery, it could be a knee replacement, a hip replacement, rotator cuff, cataract surgery, those surgeries, instead of going ahead and getting those while they're still working, they're waiting until they go on Medicare. The reason is because maybe their work plan has a high deductible and they don't want to worry about that. So they endure the pain of those physical problems, and once they go on Medicare, they're on Medicare a month or two, and all of a sudden they're in their operating room taking care of those surgeries. Well, we're seeing an increased use of those services and increased claims, and that also has affected the increases that we've seen in the last couple of years. And again, we think that's going to stable out as we move forward. But that has caused some pain to those of you on MedSup plans. Now let's talk about the market outlook. We really are optimistic. Prior to the last couple of years, companies took increases, but we would see maybe a 5% or 7% increase, and that was average. But lately it's been more like 10, 15, sometimes even 20%. So again, that's been very painful. But again, we're very optimistic about things being a little bit more stable as inflation gets under control and as we see less of the effects of people delaying surgery and such during the COVID years. Now, also want to talk about options. So as we talk about these MedSup plans, and if you decide you want to do some switching, what are your options? Well, there are some of you that are still on Medigap Plan Fs. Now, if you started Medicare before 1/1/2020, F is definitely an option, and you may be on an F plan, but the problem is you've been on a while, probably 8 to 10 years, maybe longer, and so those prices keep edging up. And so if you're on an F plan, what you have the option to do is you could go down to a G plan, or you could go down even farther to an N plan. Let's talk briefly about these plans. F is a full coverage plan. It covers all the Medicare gaps. There's 6 gaps in Medicare, and all 6 of those are covered by the F plan. All right. And so the F plan's full coverage, again, it would be the most expensive. If you move down to a G plan, what happens is that G plan actually covers 5 of the 6 Medicare gaps. So the one gap that G does not cover is called the Medicare Part B deductible. This year, that's $257. We do not know what it's going to be yet. It hasn't been published yet. As we wait for Part B premium, we're also waiting for the deductible. But again, it's an annual deductible this year, $257. I would suspect it's going to go up a little bit next year. But if you have a G plan, everything's covered but that one item. And then the plan below that, a very popular plan, is called the N plan. And so the N plan actually covers 4 of the 6 gaps. Again, great coverage. What it doesn't cover would be the B deductible, right? $257 this year. And it doesn't cover excess charges. Now, I want to pause for a second, talk about excess. Excess means that you're seeing a Medicare provider, but they're not under the contract where they have to take Medicare reimbursement rates as payment in full. And so what they can do, they can add to the bill. And when they add to the bill, they add 15%. That's the most they can add. Now, there's 8 states where it's not possible to even do it, but all the rest of the states allow it. But the issue is this rarely happens. Medicare providers can do it, but most of them are under a contract called an assignment contract or a participating physician where they cannot add excess. Less than 5% of the doctors can even do it, and even them, sometimes that are not under contract, don't do it. They just don't. But it can still happen, and if it did happen to you and you had an N plan, that excess charge would be your responsibility. G covers excess, F certainly covers excess as well. And so that's the N plan. One more item, if you go to the doctor on an N plan, you have a $20 copay, and if you go to the emergency room, you have a $50 copay. And so let me show you why people make these changes. Right now, an F to a G would probably save someone minimum of $50 to $75, maybe even $100 a month or more. So that's a good move. If I do a G, I also could do a G to a G if my premium's bumped up and I want to stay within G to have the same coverage and be able to find a carrier that will offer a better rate. That's possible. Or if we go down to an N versus a G, then I'm even going to save more money. So the difference between G and N right now on the average state, and again, this varies, this is going to be anywhere from about $40 to maybe $50 a month. So you're saving about $500 to $600 a year, and sometimes even more. So sometimes people like the N plan because there's very little additional risk beyond the G. Others say, that difference is not going to make or break me. I'll just take the most comprehensive plan available. And so my whole point is sharing with you, these are your options. And again, if your premium's gone up and we can move you and switch you and save money, either to the same plan or to a lesser plan, that may be, this may be a good time to do that. All right, now let's talk about underwriting, because in most states, you're going to have to go through the underwriting process to make these switches. Now, in New York, Connecticut, Massachusetts, never. You can always get a MedSup plan. But in most states, you have to go through underwriting. And all that simply means is that we're going to have to ask you about 35 or 40 health questions. We're going to check your medications. May get a statement from your doctor as that's necessary, but usually not. But we take this underwriting information based upon your health questions and your meds, and we give that to the insurance company. And if they see what they like, meaning they're not concerned about any of your health conditions you have, or maybe you're very healthy and take few meds, then they can approve and will approve that policy. But if they see something in these records, questions that we've asked you, such as psoriatic arthritis, maybe rheumatoid arthritis, spinal stenosis, osteoporosis, you're being treated for AFib, you've had cancer in the last couple of years, then there's certain health issues that if they see that in the questions, then they have every right to decline you. And so the point is, typically to move these plans, we're going to have to go through underwriting. And if we do, and you get approved, that's great. If you don't, there's been no harm done whatsoever. Now, I want to clarify something. Every carrier is a little bit different. For instance, one carrier may care about body mass. They ask us height and weight. The majority of carriers do not. We may have a carrier that will take a medication, let's say one for depression. If you're on it 2 years or more, we have one carrier won't approve it. Other carriers don't care. And so there are some carriers that if you're an insulin-dependent diabetic, they won't look at you. Others will as long as you take less than 50 units of insulin a day and you've had no diabetic complications. And so there's different companies that have different variables with things they're looking for and things they'll decline. And as brokers, of course, we're aware of that. So we do everything we can to make sure we can get you through underwriting if that's possible. And again, if you don't pass underwriting, no harm done whatsoever. Now, I do want to clarify that there are some states that are called the birthday rule state. These are states where around your birthday, maybe 30 days before, 30 days after, or 60 days from your birthday on, where you actually can move carriers. So we take a plan G, move to a G, or a G to an N. And we can do that without underwriting during those birthday periods of time. And again, there's about a dozen states that allow that. Now, keep in mind, if you're healthy, you can move it any time you want to. But if you have some serious health problems, it may be possible because you can't get through underwriting that you can only move during that birthday period. And again, there's states that have different rules. All right, so let's close this out with switching to an Advantage plan. There will be many people that are going to do this year. Why is that? Well, because they've had these rate increases. And those premiums are just no longer going to fit their budget. And so if you are in a position where these are really no longer affordable, then you can switch to an Advantage plan. Number one, there's no underwriting, okay, at all. If that plan is in your zip code, you can have the plan. But here's the key. If you're going to make this switch, the only dates that we can do this is October 15th through December 7th, and that's it. And so your MedSup plan would be yours until December 31, but we have to make a decision to switch to an Advantage plan during these 7 weeks. And when we make that application, what that does then, that will kick in that Advantage plan to go effective January 1. All right, so we make the decision during the 7 weeks. Our MedSup plan is ours to the end of the year, and then you cancel that, and Medicare Advantage then goes effective the 1st of January. So those are your options for supplemental plans. All right, that brings us then to standalone drug plans. If you're on a supplemental plan, then you also have a separate Part D plan. These are for the meds that you personally administer. Professionally administered medications are covered by A and B, but those that you take yourself, you pick up at the pharmacy or use mail order, those are covered through Part D plans. And so if you're on a Part D plan, what is going to be changing? So the most important thing that I can tell you about Part D plans is this right here, which is an acronym that stands for Annual Notice of Change. Now, this should be in your possession. They're supposed to have arrived by October 1st. I talked to a client today. Today's the 6th of October. He didn't get his, and so I advised him to call his insurance company, the number on the back of the card for customer service, and let him know he didn't receive it, and they'll send out a new Annual Notice of Change. The plan that he's on for 2025, the Annual Notice of Change will disclose to him everything that's changing for 2026. And so you want to be sure that's in your possession so you know what your plan is looking for. I talked to another gentleman today. Interesting enough, he's on a very low-cost drug plan, 50 cents. And when we talked about it, he said, maybe at worst, it doubles in price. It didn't. It actually went to $9.60. Not a huge deal, but he was very shocked by that. He thought it would go from 50 cents to $1. Actually, the plans could have moved as much as $50 this year. Most of them did not, but they could have. But you find that information in your Annual Notice of Change. And if you don't look at it and you allow the plan to automatically renew, then what happens is you're stuck on that plan for 2026. So please do your due diligence and read the ANOT. All right, so what are you looking for? Well, looking for the premium. Like I said, his plan this year was 50 cents, and it moved to just a little shy of $10 on a monthly basis. So it changed, right? And so you're looking for that. Now, the rules this year, Medicare allowed Part D plans to go up no more than $50. And we've seen about 20% of the plans actually taking that maximum $50 increase. We've seen some just take a few dollars. Some even went down a little bit. But the whole point is be sure you know what the premium is. It can have gone up no more than $50. All right, now, deductible. This also changed. This year, 2025, our deductible was $590. 2026, this number is out, and that deductible went to $615. Now, one thing that's very important about this is that there are some meds where the deductible is not applicable. And when you run your report to know what drug plan you need to be on, as it lists out the medications that are covered by your plan, some meds will say deductible exempt and others will say deductible. So if it says deductible exempt, what you have is a very typical low copay. Could be $2 or $5, but it's a low copay and it doesn't apply to the deductible. But if you're on a Tier 3 medication, Tier 4 or 5, that would be expensive generic or any brand name medication, you are going to have to satisfy that deductible. So the point is you pay 100% 100% of the cost of those medications until you reach your deductible. So you need to be aware of that. Again, a lot of times people never meet it, or you have meds that are deductible exempt, but I want to make sure you're aware of the deductible. Now, we also have a max out of pocket. Now, this is across the board. Medicare set this rule as part of the Inflationary Reduction Act. So this year, the max out of pocket on medications that are in the formulary, okay, in the formulary, the max out of pocket this year is $2,000. That bumped up 5%. So next year, the most a person would ever spend out of pocket would be $2,100 in 2026. I have people that are on medications that are $35,000 a month, or self-administered chemotherapy pills, $7,000 a month. You will not pay that for those meds. Once you hit $2,100 out of pocket, you can put your wallet away, your purse away, you're done. Medicare and your plan are going to cover the remaining expenses. All right, so that's the max out of pocket for 2026. Now, this is a website of ours called MedicareSchoolEnrolled.com, and you can go there and actually look at the plans that are available. And this would be a site that's really, frankly, very user-friendly. You can look at your meds, put your meds in, the pharmacy choices, and actually look at those plans and actually enroll through this site as well. So we're making that available to you if this is something that would be helpful. And then lastly, I want to talk about this. Now, up here we said standalone Part D plans, and that's the arrangement that people have when they have A and B and a supplemental plan. They have a separate drug plan called standalone. However, what happens with people who enroll into an MAPD plan, this is a Medicare Advantage. PD meaning we have a prescription drug plan embedded. So Medicare Advantage covers my inpatient and outpatient care. The prescription drug plan now covers my self-administered medications because I don't have a standalone plan. It's actually included. Now, also want to mention this, Medicare Advantage versus Medicare only. Now, what this means, this is an option only for one of three groups of people. Those that get their meds through the VA, those that are retired military and have TRICARE for life, and those that are retired civil service that have FEHB, Federal Employee Health Benefits. Could be GEHA, could be Blue Cross Blue Shield, whoever you have through FEHB. And so what happens is those three groups of people, TRICARE, VA, FEHB, can actually enroll into an MA-only plan, get their meds, not through a standalone Part D plan or embedded, but through their own drug plan that's considered to be credible coverage. And when they do that, what happens is they take advantage of that Medicare Advantage system, some of the perks that go along with it, and then almost always there is going to be what we call a Part B give back. Part B give back. So because that Advantage company doesn't have to pay for your meds, you get them elsewhere, then they take some of the money they get from the government monthly and they credit that back towards your Part B premium, which means either your check goes up or your Part B direct bill goes down. Either way, you're going to get some kind of credit. And those are going to vary. I heard about a plan today, actually in Florida, and the Part B give back was $185 on an MA-only plan. I looked at another one a couple days ago. I think it was $120 a month. But if you have a plan that has that sizable Part B give back, you enroll in that, then the advantage is you'll see your Social Security check increase or your Medicare Part B premium decrease. So those really are legitimate. Now, not all the plans have that, but there are some today in every market. All right, so that's something that you may want to consider as well. All right, so that brings us now to those of you that are on Advantage plans. What's going to be changing for you? So first off, I want to note there's 2 million disruptions within the Medicare Advantage system. That means 2 million people that are on Medicare Advantage plans, and those plans are being terminated, meaning they're gone. And so what happened prior to this year is that basically insurance companies did all they could to get new members and enroll those new members. Well, 24 and this year have been very hard on them just because of all the claims and all the inflation that even has affected those Medicare Advantage plans. So now it's not just the name of the game is enrolling anyone you can, but they want to be in markets that are profitable for them. And so they're pulling out of markets that are not profitable, pulling out of areas where there's just not enough people that are interested in that plan. So again, they're being terminated. And they have every right to do that because Medicare Advantage plans are only an agreement for 1 calendar year between Medicare, the insurance company, and the person enrolling. And so we're going to see a lot of disruption. Those plans are going to be terminated. There's also a lot of plans being crosswalked this year, meaning the plan's no longer available, but that company's not pulling out of the market. They have something else. It's just a different plan. So they automatically enroll you into that plan. It just has to be similar. It's not the same for sure. If it's the same plan, they'd be renewing the plan, but they're not. They're terminating it, but they're crosswalking you into another plan. So you want to make sure if you get crosswalked, because it's just similar and not the same, pay attention. Is that plan really going to be in your best interest? Okay, so once again, what do? do when we're on a Advantage plan, just like a drug plan, read your annual notice of change. Should have it in your possession. If not, call the company and say, I want to know what's being changed for 2026, and your ANOC is going to reveal all that information to you. All right, so if we're going to be looking at the ANOC and comparing that to other plan options this year, then what are you paying attention to? Well, the first thing is out-of-pocket expenses. What are your copays to go to the hospital, to see a specialist, to see a primary care doctor? How about if you had an MRI or a CAT scan, or you had an outpatient surgery? Look at the copays that are provided in that summary of benefits in that annual notice of change. Also, look at the providers. We're seeing a lot of change this year from PPOs to HMOs, or PPOs to HMO POSs. It's an HMO network with an out-of-network option for you. That's the POS, or the point of service. It's kind of a movement in the market this year. But the providers are networks. That means these are doctors and hospitals that agree to take the plan. And sometimes we'll see a doctor that takes the plan 1 year and then pulls out and is not going to take it the following year. So you got to be paying attention. Are your providers within the network of that particular plan? All right. And then prescriptions. How are they covered? Again, just like standalone Part D plans had to make adjustments because of this max out of pocket of $2,100, so had the Advantage plans. And so we're seeing changes. And so you want to make sure that your prescriptions are covered well by that plan. Even if your doctors are a network and you like the max out of pocket, if your prescription is not covered, you're probably going to need to have a different plan. And then pay attention to the perks. There's certainly not going to be an increase in perks this year. We probably hit the high in 24 and 25, but in 2026, some of those perks are going to be decreasing. Now, they're still going to be available. Most of them are still going to have some kind of a wellness benefit, like a gym membership, some type of a hearing aid type of allowance, or a vision allowance, dental allowance, those kinds of things. But pay attention, because some of the plans with their dental, they're going to comprehensive only, they're going to cover preventive only, no longer comprehensive. Sometimes they'll give you a blanket allowance of maybe $1,500. That includes everything, comprehensive as well as your preventive services. But just look at that. And then they have over-the-counter cards and all those kind of flex cards. But again, I'm just encourage you, read about the details on the perks, how to use them. Do you have to use a network provider, or is it something you can use out of the network and just get reimbursed for? All right, so pay attention to that. Then number 4, I just talked about this, but we're seeing a big shift between the different types of networks. So an HMO plan traditionally has meant you had to stay in the network. You couldn't go out of the network unless it's an emergency or an urgent care situation. If you went out, you paid all the expenses. PPO plans were very popular, but the problem is not profitable for the insurance companies. And so what's happening with the PPOs, we're going to see less and less of them in 2026. Companies just cannot simply make the kind of margin they need to make. So this typically is what we've had the last few years. But this year, we have this trend of HMO POS. And I said earlier, that stands for point of service. So it truly is an HMO network, but you have the option to go out of the network as long as that provider will agree to take that particular plan. So similar to PPO, but not exactly, but you still have that out-of-network option. So again, we're going to see a huge movement to HMO POSs. I also want to mention we're going to see a plan called a chronic SNP plan. Chronic SNP, and that means this is a chronic health condition that you have. It could be diabetes, it could be some kind of heart issue, it could be a lung issue, but different ones. And if we have a chronic issue, you enroll into an Advantage plan that's called a special needs plan. And so now we have special programs to address those chronic conditions. Medication coverage. Typically you can go to a specialist for that chronic condition, and you pay a normal primary care copay for that. And so meaning they're designed by these companies to address those chronic needs that you have. And so a lot of people will be taking those as well. All right, and then we have AEP versus AEP. I just mentioned this because AEP is where we are, we'll be here in just a few days, 9 days, right? And that is going to be October 15th to December 7th. And so this is a time that, again, you can change Advantage to Advantage. And when you do that, there's no underwriting involved. And of course, we'd love to help you make that switch to make sure you're going to be on the right plan. But that's AEP, October 15th, December 7th. When we make a change during this time, that new Advantage plan will kick in effective January 1. And then we have a second opportunity every year, and that is called OEP, which stands for Open Enrollment Period. And those dates are January 1 to March 31, the OEP. Now, the key to being able to use the OEP is you must be on an Advantage plan on January 1. And if you're on one, then you have the next 3 months where you can switch plans if you need to. Now, the majority of changing will be happening here, but we do have the second opportunity over there if someone's unhappy with the switch that they've made. All right. And then lastly, I want to talk about Advantage to Advantage and Advantage to Sup. So if I take Advantage to Advantage, I have no underwriting. As long as that plan's in my zip code, you can make the switch, no questions asked whatsoever. All right. Now, Advantage to Sup is a little bit different. If I make an Advantage plan, get off my Advantage and move to Supplemental plan, if I've been my Advantage plan, let's say for a year or 2 or 3 or 5 or 10 years, I'm on that Advantage plan and I will move to a Supplemental plan, other than New York, Connecticut, Massachusetts, you are going to have to go through underwriting to make that switch. And again, what do? Well, they're looking for pre-existing conditions that they're concerned about. And if the insurance company doesn't like them, they don't have to approve you. So again, if you want to make that switch, that's possible. Sooner the better, because you have to health qualify to do that. 40 health questions. We check your medications. Again, there's no exam or blood work or anything. It's just simply a health questionnaire, but we submit that to the insurance company. And if they like what they see, they're comfortable with your health conditions, they'll approve the policy. And then your Advantage plan would expire, terminate on December 31st. And that new MedSup plan with that drug plan would start then January 1. So those are your options for Advantage plans. All right, that brings us then to our final slide. And I think you know that during this period of time, there's a lot of activity, certainly lots of emails, a lot of TV ads, a lot of correspondence that you're getting in the mail. And so there's a lot of opportunity for you to switch plans, but also people that want to help you. And there really is a difference in these people that are reaching out to you. Their knowledge, their reputation, their experience, the service that they offer. So it really varies. And so just want to take a couple minutes and really talk about those different options you have. And we're actually going to rate them from lowest to highest or worst to best. And so let's look at them real quickly. So first off, I know you're getting cold calls, especially with all the robocalls that are occurring now. And frankly, I hate those. When I get those, I immediately go to my phone and I push block contact. I'm not interested in any kind of cold calling. However, it obviously must work because there's a lot of people who still do it. In my opinion, I wouldn't trust that system whatsoever. I think you could possibly get scammed. And there's a lot of a risk involved in who is that person that's actually reaching out to you, because I know some of these actually come from overseas. So to me, very, very dangerous. That to me would be the worst option. Number two, you have 800 numbers on TV. They're advertised constantly through the AEP. I want to make sure you know what's happening when you see that. Almost always, not always, but almost always, when you see an 800 number and there's no insurance company attached to that, you're actually calling into what we call a third-party marketing organization. All they're doing is generating leads. And you realize when you call in an 800 number, they're going to take your name and they're going to sell that to multiple different insurance companies, okay? You're going to go on a list and you're going to get all kinds of calls. And the interesting thing about the 800 numbers, sometimes we'll see an 800 number going to a certain company, and then they have 4 or 5 or 10 other 800 numbers that they advertise other places, but it all goes in to that same call center, okay? And so I'd be very weary about that for sure. Again, you just become a name, and that is going to be sold to multiple people. So be aware of that. Number 3, we call a call center. Now, when you happen to do business with a call center, and just so you know, I'm not saying it's wrong to do business by phone. We do a tremendous amount of business by phone. But a call center means you called an 800 number and you're going into a call center, which is kind of like a sweatshop, honestly. Normally there are multiple hundreds and hundreds of people in that call center, sometimes even more than that. There's a tremendous amount of pressure. There's a lot of turnover. Where I reside, we actually have 2 large call centers. So I hired people out of those places. And the difficulty with a call center is every time you call in, you get a different agent. That agent may be experienced or may be a rookie, may be honest, may be not so honest. And so you really never know what you're going to get with the call center. They typically also really want to push specific plans, almost always Advantage plans, because they pay us a higher commission with those. And so again, call centers, at times you may experience something good, other times could be very, very lousy. And then number 2, we call these captive agents. Now, just so you know, I know a lot of captive agents. They're well trained and frankly, they're great folks. And when someone's a captive agent, this just simply means that they are an employee of one company. They work for ABC Insurance Company. They work for XYZ Insurance Company. And rest assured, whoever they work for, they're going to tell you they're the best, they have the best plan and all that. They all say the same thing. Okay, and so what happens here when you call in, they may know what they're doing and typically do know what they're doing. But the problem is you don't have a lot of options. Why? Because they represent one company, and that one company's limited portfolio may only have a couple of options. It may be a great fit, but you don't know because, again, they're going to push what their company is selling. And that's why we and others like us, we're certainly not the only one who have done this, we follow the independent broker model. Very accepted by Medicare, and this is a system that others, of course, that have done business with, and we choose to do business this way, but we're independent. We're not beholden like the captive agent to any company. We're beholden to our clients. We're brokers. So that means when we talk with people on the phone or face-to-face, wherever, we are going to show them lots of options, many options. Now, not every single company, no one writes for them all, but we write for the majority of them. And so we pick and choose who we know is going to provide good rates, good stable rates, good coverage. And so those companies we write for. And so we really are committed to the clients, kind of like a fiduciary relationship, to make sure we're doing what is in the best interest of the client. And so because we know one size doesn't fit all, like the captive agent has to believe, we know that it doesn't. So we want to look at lots of options. We want to compare benefits. We want to compare premiums. We want to compare stability of rates. So those are the things that we look at whenever we have a relationship with someone. So we've actually chosen that. And frankly, we believe this is truly the best way to go about it because we hold your hand through the whole process. With us, we'll help you even enroll into Medicare if that's the need. We'll help you appeal IRMAs if that's the need. If you want to do any of these kind of switching that we just talked about, a Medicare Sup to another one, or Medicare Sup to Advantage, or Advantage to a Sup, we will facilitate that and really help you to make sure that you're making the very best decision for your particular situation.